Hi everyone. Great, I'm going to get started. Welcome to our Pacific Digital Health webinar series. Today we're going to be talking about EMRs and data warehousing and doing a deep dive into health data. So in case you're not already aware, we do have, this is part of a series, and so our next webinar will be coming up on the 14th of November, and we're going to be talking about HL7 fire in the Pacific and some practical use cases. So pop that in your diary for the 14th of November if you're keen to hear a bit more. So in terms of today's webinar, we are going to be looking at EMRs, data warehouses, and a deep dive into health data. I'll be your host today, and my name is Georgia Mulianga, and joining me doing the presentation will be Juliana Mitchell-Wong, our Head of Data Engineering here at Beyond Essential Systems, Crystal Prenter, who is one of our project managers who is based in Palau, and Corinna Minko, who is another one of our project managers based in Nauru for a long time. And we also have Vicky Bennett joining us, who is the Program Director for the Pacific Health Information Support Hub. Now, I'll start off by saying that today's webinar will focus on the IT and software side of data aggregation, along with the BA required at the project level. There are also many resources and mechanisms for aggregated reports based on standard clinical terminology sets, such as SNOMED, LOINC codes, CPT, ICD-10. Our session today, which will be delivered by Vicky Bennett at the end, will look at the benefits of ICD-10 coding for morbidity for the purposes of reporting. But what we won't be covering is the broader sweep of aggregating data sets from standard terminology. This is actually a huge topic and it deserves a complete webinar. So early next year, we're going to have a whole webinar just based on this. So without further ado, I'm going to hand over to our Head of Data Engineering here at Beyond Essential Systems, Juliana Mitchell-Wong.
Thanks, Georgia. Today I will be presenting on data warehousing of Tamanu's data for analysis and reporting. Next. So this is an overview of what we will be covering. We will start with an introduction and answer the question of what is a data warehouse? This is followed by exploring our data stack to provide insight into the tools we use to move, store, and process electronic medical records from Tamanu to data sets for use in Tupaya for analysis and reporting. We will then touch on the different data modeling techniques used in operational databases and in the data warehouse for analytics and reporting. And we will finish off with the different types of analytics and reporting on Tamanu data that is currently available in both our Tamanu and Tupaya products for end users. So what is a data warehouse? It is a central repository of data from multiple sources. We can categorize our data source as either from an operational system or static data. Operational systems include electronic medical record systems such as Tamanu and logistics management information systems such as mSupply. Static data include population and organizational hierarchies such as defining a country's province, district, and villages. It is designed to be used for analytics and reporting, and it is part of the ELT pipeline. So E is for extracting data from a source. This can be by data replication, API, or restoring from a backup. L is for loading into the data warehouse, and T is for transforming the data in the data warehouse. So let us expand on the ELT pipeline and look at the data stack we use at BES. As discussed earlier, we work with many different data sources, including Tamanu and mSupply. Data integration is the EL, or the extract and load processes. In this section, we code in Python to extract data from our source and load it to our Postgres data storage or warehouse. For data transformation, we are using dbt, which is processed within the data warehouse. We have an orchestrated Dexter that coordinates the schedules and execution of processes, and it doubles as our data monitoring tool. Finally, we have data that is served for analytics and reporting into Tupaya. So it's now time to dive a little deeper into our data structure by looking at modeling techniques. We present this in tabular format for easy comparison of the two techniques, relational and dimensional. Relational modeling is ideal for transactional or operational databases. This means it works well for create, read, update, and write operations, and is normalized for data integrity and consistency. This modeling is based on the concept of tables, columns, and rows, where tables represent an entity or subject such as patients. Columns represent the attributes of the entity, such as the patient's age and sex, and rows represent a record or instance of an entity. Dimensional modeling, on the other hand, is ideal for analytics and reporting. It works well for read and aggregate operations and is denormalized, which means increased data redundancy and dependency, but improves performance and usability. This modeling is based on the concept of facts and dimensions. Facts are the numerical measures or indicators of business performance, such as number of patients that had a clinical encounter, and dimensions are descriptive attributes or categories that provide context to the facts, such as date of encounter, patient's age, and sex. Let us look at these two different modeling techniques through examples from Tamanu's operational database and the data warehouse. Relational data modeling can be found in Tamanu's operational database. We will look at two tables here, patients and encounters, which are on the right of the screen. What we can see here is the list of columns in the tables. The red box consists of the primary key of the tables. It is represented as ID in both tables. It is used to uniquely identify a row or record in the patients or encounters table. The green box consists of columns that represent attributes of the patient or encounter. And finally, the yellow box consists of foreign keys that refers to the primary key of another table. This is how we form relationships between tables. And the rest of the fields provide metadata, which assists with the operation of the Tamanu application. So data normalization is intrinsic to relational modeling. It is a technique to reduce data redundancy, thus providing data consistency and integrity. Listed here are three normalization levels which builds on top of each other. So most relational databases will follow the third normal form. The first normal form looks at data atomicity and removes duplicates. Data atomicity is where you ensure you have only one value for each field. An example would be a field for a patient's full name. To fulfill one NF, the full name field has been separated to first, middle, last, and cultural name. These fields are in the red box. Another property of the one NF is ensuring that there are no duplicate rows. This ensures that we do not have the same patient represented multiple times in a table. 2NF removes redundant data from a table that is being applied to multiple rows. An example of this would be listing the patient's information in the encounters table. Instead, we have a separate table to represent the patient's information so that we only store this information once and provide a reference to that. The green box illustrates this example. This is where patient ID in the encounters table refers to the ID in the patient's table. And we get to the 3NF, which removes transitive dependencies. So let us look at the example of location. In the real world, location represents beds in a location group or ward. So if location and location group was added to the encounters table, that would violate 3NF because location group is dependent on location. So the yellow box illustrates this example. So to comply with 3NF, the location ID in the encounters table would reference the ID in the location table. And within the location table, we have a location group ID, which then references the ID in the location group. So we are representing the data only once. So let us move on to dimensional modeling. This is a sample of some relevant tables in our data warehouse when reporting on the total number of encounters. In the middle, we have the encounters fact table. Each row represents an encounter record and connects to a number of different dimension tables, which provide context to the data in the fact table. This resembles a star, and is the reason dimension modeling is also referred to as the star schema. So the date and time dimension tables are a convenience table put together to map different ways we could slice and dice our data based on date and time, such as by calendar year, July, June year, and epi year. Whilst the location dimension table provides all information related to a location, such as location group and facility, you would notice this is in a denormalized form. So this redundancy in information improves the performance and usability of data by reducing the number of table joins required to build our data sets, which is in the top right corner. In this data set, we are interested in dicing and slicing the data by day, hour, facility, location group, department, encounter type, patient's village, age category, and sex. You can see it's a lot easier to slice and dice our data when it's in this format versus when it was in the normalized form. So to summarize dimensional modeling, sorry, next slide. Dimensions are denormalized, and they provide a way to standardize attributes of a dimension that the data set can be sliced and diced by. For example, by having a date dimension table, all data sets will use the same field names and definition to represent the same data categories, such as we mentioned, calendar year, June, July year, June year, and epi year. Facts have foreign keys to dimension tables, and they contain numeric measures that can be aggregated, such as counting the number of encounters, summing the number of procedures during an encounter, or averaging the length of an encounter. So to the final section of this presentation, analysis and reporting. Here we can visualize where the end user can access Tamanu data for analysis and reporting. So BS provides some standard Tamanu database reports, which can be executed against the raw schema in the operational database on both the facility and central servers. We also have a reporting schema that sits on top of the operational database on the central server. This is based on a tidied up version of the raw schema. Our end users can create their own customized reports using this schema. Because Tamanu's database reports are running on the operational database, our recommendation is to only use database reports for accessing identifiable data or data that's required in real time to minimize the performance impact on the operational database. This is where the data warehouse fits in, as it is built for analytics purposes. It does not hold identifiable data, and some analytics and reporting can be complex and thus resource intensive. For these reasons, we recommend working on a separate database instance that is not your operational database to process the data. This data can then be used by a BI tool such as Tobias VisBuilder. So let us take a look at the differences between Tamanu database reports and Tobias VisBuilder for reporting through a simple example of reporting on the count of encounters by age group. So this is a screenshot from Tamanu's central server admin panel, where we can create a custom report. So we give the report a name, select a default date range for the report. Here we've selected all time, and there are other options including past 24 hours, 7 days, or 30 days. We can include a description for the report, and we write the SQL query on the reporting schema. And on the right here, we can set parameters to filter the report. In this case, we have not set any parameters, but date selection is available by default. Note here that when creating a report on the normalized database, you will have to define the age categorization in the query each time the report, for each report that you are creating that requires age categorization. Whereas in the data warehouse, which I'll show you later, we will only define the age categorization in a table which can be applied across multiple data sets. So once the report is configured, To generate a report, we switch over to Tamanu's facilities server admin panel. We will select the report and configure or filter the results of the report before generating the report, which will be delivered to an email. Okay, let's move to reporting in Tupaya. The first step here will be to bring the data into Tupaya through data tables. We would give it a code and description, select a permission group, and select the database connection. So similar to Tamanu database reports, we would then write the SQL query and set parameters to filter the data set. In addition, we can have a parameter that defines the fields to aggregate by. So if we compare the SQL here with the one written in Tamanu, the query is very simple because most of the complexity has been moved to the data warehouse, and there are a lot more fields that we can filter or aggregate the data by, whereas in Tamanu, we've only set it up to filter by date and aggregate by age category. So in Tupaya's VisBuilder, you can access the data table that we created using the fetch data transform. Since we're interested in the count of encounters by age category, we can choose to group by age category. And because in the data set, we define the total encounter metrics can be aggregated by summing, we will get a sum of encounters by age category. So the second transform at the bottom is a SQL transform just to rename the columns for presenting the data in the visual. So if we toggle to the chart preview in Tupaya's VisBuilder, we can preview the visual. In this case, we have chosen a bar chart. And as you can see, it is very simple to build visuals once we have the data organized in a data set. So I hope I've demonstrated how data warehousing has shifted the complexity of building data sets to the data warehouse, making it easier for end users to perform analysis and reporting on EMR data, and also introduces some standards between data sets. So the two case studies coming up will draw out some of the complexities in defining the business rules and logic that are applied at the data warehouse. Thanks.
Wonderful. Thank you so much, Juliana. That was really interesting to hear about the complexities that go on behind the scenes with all of the data and getting it into a usable format. I'm now going to hand over to Crystal Brenter, who is a project manager at BES, who has been working mostly in Palau with the Palau National Hospital. And she's going to be giving us a case study on how we take all of this data and make it something that's usable and what sort of goes into that process. So over to you, Crystal.
Thank you, Georgia. Yes, so as Georgia said, my name's Crystal. I am the project manager for Project Olang, which is based in Palau, working with the Palau Ministry of Health and Human Services and primarily with Palau National Hospital. So for the purpose of today, I'm going to focus on just one particular dashboard that was built for Palau National Hospital, which is around hemodialysis reporting. Next slide, Georgia. So Project Olang consists of 4 platforms within their digital health ecosystem. So Tupaya was the first to roll out in July 2022. So as we know, Tupaya is our data aggregation and visualization platform. MSupply was the next one to roll out in October of 2022. And MSupply is our supply chain management system. Tamanu, which we know as our electronic medical record system, was next to go live in August of that year. And then Senite was the most recent addition, and Senite is our lab information management system, which is used within the lab in Palau National Hospital, and that rolled out in August of last year. So as I said, for the purpose of today, I'll just be focusing on the hemodialysis dashboard and reporting. But as you can imagine, there are a number of different data requirements and dashboards that have been built for the Ministry of Health within Palau. So within Project Olang, we began by using Tupaya MediTrack, which is an app to capture data to populate dashboards. But nowadays what we do is the data aggregates directly from Tamanu into tupaya.org. And what this does is it reduces those accidental data entry errors. It improves that real-time access to data for senior staff members and for senior nurses. And it also reduces the data entry burden for the nurse supervisors who were previously the ones responsible for entering that data into Tupaia MediTrack. So a typical request that we would get when wanting to build a dashboard is we want to see how many hemodialysis patients and how many backup patients we have. So at BES, we need to understand the exact requirements behind that request so that the dashboards meet the needs of what the ministry is after. So some of the questions that we might ask to accurately gauge their data requirements needs are you wanting to see this for all patients, or are you just interested in identifying inpatient or outpatients? What's the definition of a hemodialysis patient? Because it can often be easily understood when counting these manually, as it would just be the person physically sitting in the hemodialysis room. But when aggregating this data from Te Manu, we need to understand the nuances of what this term actually means. Similarly, with defining a backup patient, we need to understand the exact definition of what that means for the purpose of aggregating that data. In what time period? So what is going to be the most useful time period to visualize this data? Are they wanting to see it on a daily, a weekly, a monthly, or even an annual basis? And in what time period do they consider a backup patient? And that also leads very nicely onto what is the data going to be used for overall? So a lot of these questions help determine what we're using the data for. So we then need to help translate that those requirements gathering questions to Juliana and the data team within BES. So within Palau, we identified that they were after the full count of hemodialysis patients. Therefore, we pulled the data from location within Te Manu, which allowed for the capture of both inpatient and outpatient data. Next slide. We also needed to find out the definition of a hemodialysis patient. So the ministry's definition of a hemodialysis patient is a person who receives one or more hemodialysis procedures, which is the associated CPT code of 90935. Similarly, we needed to define what a backup patient is. So again, the ministry informed us that their definition of a backup patient is any patient who has 3 or more of that hemodialysis procedure. We then needed to identify the time period for that. So the time period is Monday to Sunday week. And they also informed us that when displaying that dashboard, they were particularly interested in seeing that data displayed monthly. And so what does the ministry use this data for? They use the data for planning their nursing staff for each ward. They use it for analysing trends, such as an increase in the number of patients receiving hemodialysis, or an increase in the number of backup patients. And it's also used for resource management, such as identifying consumables that might need to be procured for the ward. And so finally, this is the outcome. This is what the dashboard looks like in Palau National Hospital. So as you can see, we also have a blurb which talks about how the data is aggregated from Te Manu. And this is to ensure that the end users are able to independently identify where that data is pulled from in Te Manu, from Te Manu into Tupaia. So this one, for example, says that the data from Te Manu is from the 1st of January 2023 until present. The definition of total patients is the number of patients with a hemodialysis procedure of that specific CPT code within the area of the hemodialysis ward. And the definition of a backup patient is a patient who has 3 or more of those procedures within a single week in the hemodialysis ward. And we also just made it very explicit that there was some prior MediTrack data that was pulled into this dashboard if they're looking back prior years. And that is an example of how we do BA and requirements gathering in Palau. Thanks, Georgia.
Wonderful. Thanks so much, Crystal. Yeah, really great work you guys are doing there, and nice to see what comes out for the end users. I'm going to hand over now to Corinna, who's going to talk us through a similar process that she went through in Nauru with the Nauru Hospital bed state reports. So over to you, Corinna.
Thank you, Georgia. So yeah, today I'm going to be running through the hospital bed state reports that were built into Paya for the Republic of Nauru Hospital. And firstly, I just quickly want to acknowledge that what I'm presenting on today is actually the hard work of my colleague, Amanda, who's currently on some well-earned leave. So all credit to Amanda and the data team. So Ron Hospital started using Te Manu across all hospital wards and departments in June 2023. And since then, all patient encounters at the hospital are recorded in Te Manu. Alongside this rollout, we built a bunch of Paya dashboards and visuals using that information recorded in Te Manu to generate aggregate data on key indicators across hospital programs. The bed state visuals came a little later and were developed following a specific request from the Director of Medical Services at the hospital. She wanted to be able to have access to more timely and accurate information about the workloads in each ward, as well as the movement and location of patients throughout the hospital. And while we did have some existing bed state visuals, this project was developing them at a level of detail that was useful for the DMS and hospital management. Next slide. So to build these out, and to make them useful, there were several things that the data team needed to know before they could start. And to begin with was which patients and which patient encounters were actually being counted toward these visuals. So at the hospital, they used Te Manu to document outpatient visits, inpatient stays, and visits to the emergency department. And the data team needed to define which of these counts towards the information that the DMS was after. For Ron Hospital, an admission includes all patients who are staying in one of the hospital wards for a period of time. And if we go back into Te Manu, that's reflected as any time a patient was either directly checked in as a hospital admission or any time a patient was admitted to hospital from an already open ED or outpatient visit. We also need to specify which areas in Te Manu we wanted to include. So this meant providing the data team with the reference data codes for the wards to differentiate them from other areas such as outpatient clinics. For the emergency department, those stays were not included. This data is captured in specific ED dashboards as the workflows through ED are quite specific to them. In addition, in defining which types of patient visits were counted, we also combined patient level data, namely age and sex, in order to provide a more detailed breakdown of admitted patient cohorts. We also need to specify at which time period, for which time period that data should be summarized. And so that was specified as daily, weekly, or monthly, and when we were pulling that data. So I think if we go back to the previous slide, that was just for the bed state reports, counting all admissions and transfers that happened from the beginning up to the end of the day in the case of the daily reports. And similarly for weekly and monthly reports, it was populating the data at the end of that week or month to reflect the total admissions and transfers during that time period. We also have a daily ward census, which provides a snapshot of where patients are at 3 key times during the day. Now, you've probably just heard me speaking about admissions and transfers, so the next thing was to define those. For the purpose of these visuals, an admission was counted under the first ward that a patient was admitted to, but not any subsequent moves to other wards. So each patient will only have one admission per hospital stay, and this information helps us to see where patients are entering the hospital for inpatient care. A transfer was counted under any subsequent ward that a patient was moved to after their initial admission. So not every patient will have a transfer, whereas some patients might have multiple transfers. So when we look at the data or the numbers under the transfers, one patient might be represented more than once in those numbers. Transfers show us patient movements throughout the day, week, and month. For example, a patient may be admitted to the male ward transferred to CCU, and then back to the male ward. This patient would have one admission to the male ward, one transfer to CCU, and one transfer to the male ward. One thing the data team came across when they were pulling all of this together is that when a patient is moved, there are technically a few things that are changed in their Te Manu record. The ward they're staying in is updated, as well as the actual bed they're staying in, and sometimes also the department looking after that patient. So it was really important, in order to avoid, double counting a patient's transfer, that they set a rule that only one of these location changes was counted. Once a patient is discharged, that ends their current hospital stay, and if in future they're readmitted as an inpatient, they will start that count again. So we'll have a quick look at some examples of the visuals that were created. This one is looking at our daily ward census, which shows the number of patients in each ward at 7 a.m, 1 p.m, and 11 p.m. each day, effectively at the beginning and middle of regular operating hours, as well as at the end of the day itself. So this is really a snapshot in time of where all admitted patients are at that point in the day, regardless of if it was their initial admitting location or a subsequent transfer. We also have the bed state reports, and these have the data is presented daily as well as weekly and monthly. And they summarize the total admissions and transfers to each ward. So these display data at the end of each time period and capture the total admissions or movements throughout the day, week, or month. Next slide. So how has this been helping at Ron Hospital? So having access to data at a daily level, or even 3 times a day, allows management to respond to immediate requirements, such as spikes in resource requirements and the potential need to temporarily up staffing in a ward. Having weekly and monthly visuals helps to show the data over a longer period, which perhaps more accurately reflects the average resources required by a ward. And this kind of data can help for long-term planning, identifying where and what level of resources should be allocated, and predicting and planning for known busy periods ahead of time. Similarly, long-term analysis of the daily ward census can indicate at which points in time the most beds are occupied. So for example, if a ward consistently starts empty, fills up during the day, and then empties out in the evening, it can be planned that in the middle of the day, more staffing is required. So knowing when the busy times are an average will also help to identify and respond to unusual patterns early. And while this is all really useful data for reporting and staffing allocations, at the end of the day, the most important factor here is that better bed and staff workload planning is known to result in better patient outcomes. So having this data available to allow management to be able to predict and plan for when Ron Hospital is regularly busy, or to be able to respond to unexpected patterns, allows DMS and other managing staff to respond to changes in expected workloads and ensure that resources are available so that each patient is able to receive the best level of care. Thank you. So that's a little overview of how we designed those visuals for Nauru.
Wonderful. Thank you so much, Karina. It's always very impressive to see how much work goes into each of these data insights, and also, I guess, how efficiently the data team can work. We have just seen 2 examples today, but I know that there are hundreds and hundreds of these that are being produced each year across all the countries that we work in. So it's a very impressive amount of work that goes into it from all sides and all teams. I'm going to hand over now to Vicky Bennett, who is the Program Director for the Pacific Health Information Support Hub. And Vicky will be talking to us about the International Classification of Diseases and how it helps. So over to you, Vicky.
Thanks very much. I'm assuming you can hear me?
Yep, we can hear you great.
Thanks. And thanks, everybody. That's been really interesting to hear about some real practical examples on the ground. For those of you who don't know about us, we are a government agency in Australia called the Australian Institute of Health and Welfare, and we've been funded by DFAT, Department of Foreign Affairs and Trade, under the Partnerships for a Healthy Region program to establish a unit called FISH, the Pacific Health Information Support Hub, PH being the F for FISH. But one of our other key roles is working with the WHO on the development of the international classifications of diseases. So this is a bit of a crossover kind of presentation. I don't have permission to move these slides on, do I? Thanks
I'll
very
move
much.
it on.
Great, thanks. So for those of you who haven't heard of it before, and maybe I'm hoping everybody has, but the WHO have for decades created what's called the International Statistical Classification of Diseases and Related Health Problems, or the International Classification of Disease for short, the ICD. And it's a really important classification because it allows us to record, analyze, interpret, and compare morbidity and mortality data in different countries and regions, or even within a country between facilities and across time. Next one. It allows us to use that data, and for many different purposes. Those are definitely including the following: certainly health statistics, which is key. It can be used for clinical decision support. It can be used for resource allocation and reimbursement. And what we know about human disease worldwide generally relies on the recording of the ICD codes in countries. Next slide. So you might wonder who uses these things. Well, ICD codes are used primarily in the capture of this information by health information managers or clinical coders who abstract information from episodes of care and allocate codes related to either the condition that was treated or potentially the reason for death. Healthcare providers themselves can use the data once the ICD codes have been collated to analyse the care that they're giving, and I'll use some practical examples of that later. Hospitals can use it to monitor and develop clinical pathways or anticipate resources going to be required coming up. And researchers most definitely use these ICD codes for analysis of what's happened and planning and improving advances in medicine going forward. Thanks. Codes are also captured into things like registries. So cancer registries collect morphology codes and site location codes of different types of cancers. In some countries, and I guess in particular in our region, our American territories or American affiliate territories, insurance companies use these for billing. Governments use them to assess the health status of a population, and the organisation I work in does that for Australia. And international organisations use it as well. People like the WHO in particular use the ICD codes for international public health reporting on mortality. Next. So where do we capture ICD codes? In two main streams. One for mortality comes through death certificates, the medical certificate of cause of death. And for morbidity, it can be in multiple points of capture throughout a treatment episode. So it could be through at the end of an admitted episode of care. It can be related to emergency care. Codes can be captured related to primary care, aged care, rehabilitative care, really anywhere care is provided in the health continuum. Next, thanks. Mortality is the most common global use of the ICD code set, and it is used to code what we call the underlying cause of death. So, and that's defined as the disease or injury that initiated the train of morbid events leading directly to the accident or violence which produced a fatal injury rather than to the nature of the injury. So there's a lot to unpack in that. Doctors get trained on how to identify what the underlying cause of death is. The biggest mistake doctors make is they write cardiopulmonary arrest on their medical certificates. But basically every person dies from when their heart and lungs stop working. What we want to know is what caused that to happen. So that's the underlying cause of death. Next, thanks. Mortality statistics are very important and are used for lots of good reasons: research, public health monitoring, underlying patterns of mortality, evaluation of health interventions, safety and quality, and healthcare planning. So mortality statistics are very key in understanding how the health sector is going. Next one. Morbidity statistics. So not what killed you, but what made you unwell, what your disease or underlying conditions are. They are often looked at for reporting of hospital and primary care services, case mix or diagnosis related groupings, so for funding purposes, monitoring and assessing safety and quality of care. As I mentioned, cancer registries, they can be used for antimicrobial resistance monitoring. There's ICD codes for functioning, so understanding disability, and then of course, research, clinical trials, and epidemiological studies. Next one. So the next few slides relate to exact examples of how these are used. This particular graph, it's one from Australia, and it shows how the ICD code for gestational diabetes can be graphed to show hospital admissions that relate to that. And it can show that trend over a long time series. In this time series, we're looking at 20 years of data, which would have come from coders coding discharge diagnoses for people who were admitted to hospital with gestational diabetes. And those pictures that you can create using these codes tells a very important and not so great story about the fact that gestational diabetes is increasing in its prevalence of hospital admissions. Next picture, thanks. This is a mortality example of how ICD-coded data from death certificates can show the leading causes of death for young people. This one in Australia obviously shows that injuries, which includes drowning, are the most significant cause of death in that certain age group. Without this level of granularity, it's hard to understand how you would actually action any public health programs to address some of those issues. So obviously the biggest public health risk for young people is injuries. Therefore, the Australian government would be targeting this age group with public health programs to try and reduce that. If we did a different age group, like 65 plus, you would have a very different profile. You would have heart disease. You would have lots of chronic conditions in that space. Okay, next slide, thanks. This is an example about how you can use both morbidity and mortality data to analyse things. Where in this example, we're looking at the analysis shows the rate of injury by geographic location, those dimensions that were mentioned in earlier slides. So we can see that age and sex and location have a really different picture. Hospitalizations in major cities, in very remote areas is different. The pattern is more extreme. The deaths in those areas, you might start to hypothesize to say, well, actually, maybe people move to regional centres when they are acutely unwell, and that's why they don't die in that location. So there's things that by combining morbidity and mortality, that we can tell real stories. And of course, that males are much more likely in every category pretty much to have hospitalizations and deaths for these kinds of rates of injury. Thanks. Next slide. A real world problem we recently faced, COVID. As I said, I work with the WHO on the development of the ICD classifications, and I happened to be in Geneva in March of 2020. You might remember that was pretty well the very beginning of COVID, and the meeting I was at actually came up with these new ICD codes, these U codes that are in this slide, the UO 7.1 and UO 7.2 and U10, 11, 12, because we needed quite rapidly to be able to count the number of cases, and not just one code, because we needed different codes to be able to say, was it suspected? Was it confirmed serologically? Was it post-COVID condition, an adverse reaction to the vaccine? So we needed to come up with a range of codes. And so this is an example of, if there is a new and emerging disease, this is the kinds of work that happens on the International Classification of Diseases to come up with it. As I say, not just one code for COVID, but all the things that could be captured to inform the health system about how COVID is impacting healthcare and individuals. And the next one, I think, is the last. I wanted to give you a real world example that I worked on 15 years ago or more, maybe, when I was living and working in Fiji, and how we used ICD codes at a local level. So we implemented the use of the Australian version of the ICD-10. So it's the ICD-10 AM. It also has the Australian classification of health interventions, the ACHI, which is the code set for capturing information about health interventions like surgical interventions that are done. And so we've implemented ICD-10 AM and ACHI in 3 Pacific countries in around 2005-6. We're in Fiji and Tonga and in Samoa. So all of those countries have been coding their hospital discharges using ICD-10 AM and ACHI codes since that period. What we did in Fiji in particular is as part of their clinical indicator reporting program for their major hospitals, we actually came up with a set of clinical indicators, and we were able to report on those clinical indicators at a facility level using those ICD-10 AM and ACHI codes. So we picked 2 areas in particular, the first of those being lower limb amputations for diabetic patients. And we were able to use as the numerator the ACHI codes for the lower limb amputations, and there's a series of about 15 codes that relate to lower limb amputations, because obviously sometimes you only cut off some toes, or you might cut off a foot, or you cut off right up to below the knee. So there are a series of codes that describe the different level of amputation. And then the denominator that we used was the total number of admissions for diabetes, which used the ICD-10 AM codes, the disease codes, in the range of E10 to E14, which are the diabetes codes. So we were able to create rates based on that. The second area we looked at was post-cesarean wound infection. As you might know, a cesarean wound should be a clean wound and it shouldn't get infected. And if it does get infected, it shows you something about post-operative care or even intraoperative care not being conformant to the best infection control arrangements. So in this case, we were able to use the number of admissions with an ICD-10 AM disease code, which is 0686.0. There's only one code we needed here, which is infection of obstetric wound. And then the denominator, we used all the cesarean section codes in block 1340. Again, there's multiple cesarean section codes, one for a single birth, one for multiple births. So that block was then used as the denominator for calculating these indicators. Oh yeah, there's one more slide, I think. So I found it hard to find a report that we produced back then, but I dug through my file of everything I've kept for the last 20 odd years working in the Pacific. And here was one of those indicator reports we produced back in 2006 for CWM and Lautoka hospitals in Fiji, where we were able to use the rates of lower limb amputations in patients with diabetic foot. So hopefully there's some useful use cases into understanding how coding is done, why it's important, and some very specific examples of the sorts of things you can do with ICD coding. As part of our role with the fish, we are helping countries. We're certainly doing some training in Fiji and Tonga at the moment for ICD-10 AM. But as we are also the Australian Collaborating Centre for WHO on the health classifications in the Western Pacific region. And as part of our collaboration agreement with WHO, we agreed to provide support to the region more generally on the use of health classification. So if people are interested in reaching out to us, we're very happy to provide you with any kinds of information or training that we might be able to offer in the future. Thanks very much.
Wonderful. Thank you so much, Vicky. That was really interesting to see and hear about how those ICD-10 codes play into the data and those statistics we're often hearing and seeing sort of how they come into it. Sorry, I have one more slide. So everything from today has been recorded and will be up on our YouTube channel. So thank you so much everyone for attending, and we will see you in a month or so for our HL7 Fire in the Pacific practical use case webinar. Thank you everyone.